Hey everybody, thanks for tuning in to Module 9 on Pre-excitation and Supraventricular Tachycardias, part of our EKG Fundamentals series. Learning objectives for this module, you're going to be able to explain what pre-excitation is and its relationship with SVTs. You'll also be able to list the various types of SVTs that you'll encounter in the clinics or the wards. Let's review the normal conduction system through the heart. We have signals that begin in the SA node, travel down to the AV node, down the bundle of His, to the left and right bundle branches. Remember that the left bundle branch has a few additional branches, but eventually both the left and right bundle branches are going to go on to make the Purkinje fibers, which depolarize both ventricles. Now, what if we added an accessory pathway to this scenario? In other words, what if we added another pathway that allows electrical conduction to travel? While this is quite rare, it is likely that you will encounter patients with accessory pathways in their heart, so it's important to understand what may happen in such a scenario. Let's think about it. The SA node is still depolarizing both atria, eventually traveling down to the AV node and then down the regular pathway. But in addition to that, it can travel down this accessory pathway as well and go right to the ventricles. So the ventricles are not only being depolarized through the AV node, but also through this accessory pathway. What can happen in such a case? Well, because the accessory pathway doesn't have the sympathetic and parasympathetic regulation that the AV node does, depolarization of the ventricles through this accessory pathway can happen before depolarization of the ventricles through the AV node does. Let's think about what our EKG would look like in this scenario. You would still have a P wave representing atrial depolarization. And then you'll notice that two things happen. Number one, the ventricles depolarize earlier through a different pathway. So your QRS complex might have this upward slurring before the rest of the complex. And then you see your T wave. The upward slurring representing depolarization of the ventricles through the accessory pathway. And then the rest of the QRS complex representing ventricular depolarization through the normal pathway. The second thing you'll notice is that there is PR shortening. Up until now, we talked a lot about normal PR intervals as well as prolonged PR intervals in the case of heart blocks. In the case of an accessory pathway, you may encounter a shortened PR interval, meaning it is less than 3 little boxes. This again is due to the earlier depolarization of the ventricles. Finally, I want to note that this upward slurring you see initially in the QRS complex does have a name to it, and it is called the delta wave. Let's review this concept again very quickly. Normally, the heart conducts from the SA node down to the AV node, down the bundle of His, eventually to the branches and then to the Purkinje fibers. Some individuals do have accessory pathways, resulting in early ventricular depolarization occurring from signals going down that pathway. This is commonly seen in the condition known as Wolff-Parkinson-White syndrome, in which there's an accessory pathway usually called the Kent bundle or the bundle of Kent. And finally, in such a case, you would expect the EKG to show a P wave, an early depolarization of the ventricles through the accessory pathway, and then your T wave, with this early depolarization being called the delta wave. I also want to note that in Wolff-Parkinson-White syndrome, you don't always see a delta wave. This is because the accessory pathway can transmit signals either downwards, called antegrade, or back upwards, called retrograde. You would only see early depolarization of the ventricles if it's going downwards, or antegrade. This EKG is an example of Wolff-Parkinson-White syndrome. As you can see in almost any of these leads, there's definitely a shortening of the PR interval. Additionally, next to the P wave, you see this upward slurring of the QRS complex. These are your delta waves. This is commonly seen in Wolff-Parkinson-White syndrome. Let's talk a little bit more about the pathologies that can arise from this accessory pathway. What if for some reason our signals traveling down from the SA node down to the AV node down to the ventricles begin traveling back up through this accessory pathway? Remember that the accessory pathway can transmit signals up or down. In this case, it is possible that the signals going back up to the atria will once again depolarize the atria and then even depolarize the AV node. You'll notice that this creates a closed loop of atrial and ventricular depolarization. Such a condition is known as AVRT, or AV reentrant tachycardia. The name is pretty self-explanatory. There is a reentrant of depolarization going back up from the ventricles to the atria. And because we have this closed loop, the heart can beat very fast, resulting in the tachycardia. This type of heart rhythm can be seen in individuals with Wolff-Parkinson-White syndrome. And we will see an EKG of what AVRT may look like. Let's talk about AVNRT, which stands for atrioventricular nodal reentrant tachycardia. Unlike AVRT, in which we have an accessory bundle elsewhere in the heart, in AVNRT, there's an accessory pathway right inside the AV node itself. So in this case, the disease is within the AV node. If you imagine this diagram is showing the AV node here, breaking into the bundle of His down to the left and right bundle branches. Normally, you have signals coming down from the SA node to the AV node, which eventually travels down to the bundle of His and so on. In the case of AVNRT, there may be two pathways, one being the slow pathway, sending depolarization down the AV node, and the other being the fast pathway, sending depolarization down the AV node. Because the fast pathway is faster, it would depolarize the bundle of His and the bundle branches normally, and the AV node would therefore achieve refractory period before the slow pathway gets down to the bundle of His, preventing the slow pathway from creating ventricular depolarization at all. This EKG would look normal. Now let's say for some reason the slow pathway manages to come down and create a closed loop, meaning that signals manage to travel back up the fast pathway, which hasn't depolarized yet and isn't in its refractory period yet. Now we've created this closed loop again, similar to an AVRT. This would again result in atrial depolarization and also ventricular depolarization in an uncontrolled manner. This would result in the tachycardia. The reentrant in this case would be going up the fast pathway, and of course the AV node is involved. We call this AVNRT. This is an example of what AVRT or even AVNRT may look like. Differentiating between these two conditions on an EKG is difficult, while possible. However, understanding the differences is beyond the goals of this video. For now, stick to the basics. If you see a narrow complex tachycardia, you want to have AVRT and AVNRT in your differential. If the patient has a history of Wolff-Parkinson-White syndrome, then you definitely want to have AVRT in your differential. One of the things you'll notice is that the rate in this EKG is greater than 150. While it's not a set in stone rule, in general, tachycardias with a rate greater than 150 is less likely sinus tachycardia. Sinus tachycardia is usually between 100 and 150. In this case, because it's greater than 150, we would again think about some other type of supraventricular tachycardia, such as AVRT or AVNRT. This EKG shows an example of AVNRT being terminated. Because AVNRT is a problem with the AV node, oftentimes this condition can be controlled with medication that block the AV node. In this specific EKG, the drug adenosine was given. Adenosine here resulted in slowing of the heart rate and restoration of sinus rhythm. You can even see the P waves coming back. Another way to control AVNRT would be vagal stimulation, such as a carotid massage. This as well would slow the AV nodal conduction. This is a good chance for us to transition to supraventricular tachycardia, or SVT. This is a term you'll hear thrown around a lot, and it's important to know what this means. The name pretty much has the definition within it. It is a tachycardia resulting from somewhere above the ventricles. This can either be from the AV node or the atria. If you recall, depolarizations originating from the ventricles, such as VTach or VFib, or even idioventricular rhythms, tend to have a wide complex due to dyssynchrony in left and right ventricular depolarization. Depolarizations of the ventricle that start from above the ventricles, such as an SA node conduction or an AV node or junctional conduction, tend to be narrow complexes. So in general, SVTs tend to be narrow complex tachycardias. Let's quickly run through the list of supraventricular tachycardias here. We have sinus tachycardia, which we should be very familiar with because this starts from the SA node and travels down the normal pathway just at a faster rate than normal. Atrial tachycardia is a tachycardia resulting from the atria but not from the SA node. Identifying this in the EKG would require carefully examining the P wave for any change in its morphology or axis. If atrial tachycardia is resulting from many different parts of the atria, we call it MAT or multifocal atrial tachycardia. Similarly, this is not conduction through the SA node, but rather from ectopic foci within the atria. Atrial flutter and atrial fibrillation also result from abnormal disease of the atria or the vessels around it. In sinus tachycardia, atrial tachycardia, and multifocal atrial tachycardia, we would expect to see P waves. Whether they are normal or not, there will be P waves present. In atrial flutter and atrial fibrillation, there will be no P waves. You may see fibrillation waves, or in atrial flutter, what's called a sawtooth pattern from its cyclical conduction, but ultimately there are no P waves. We already discussed AVRT and AVNRT. The last one is a junctional tachycardia. Junctional meaning it originates from in and around the AV node. Again, we would expect no P waves in this condition. What about an AVRT and AVNRT? Would we expect P waves in those conditions? Well, remember that the QRS complexes are not a result of SA nodal conduction in these conditions. Therefore, we would not see a P wave before every QRS complex. However, occasionally we do see P waves marching at their own rate in these EKG strips that have no relation to the QRS complexes. This may be helpful in the diagnosis of a reentrant tachycardia. Once again, this is an EKG strip of atrial fibrillation. You'll notice that there are no P waves in this EKG strip. The QRS complexes are narrow, but they are very irregular. The lack of P waves and irregularity of the QRS complexes are pretty classic for atrial fibrillation. That's about it for today's video. We talked about what a delta wave is and how it can be seen in conditions such as Wolff-Parkinson-White syndrome. We discussed the difference between AVRT and AVNRT and how it can be difficult to distinguish between the two in an EKG strip. Finally, we went over all of the common supraventricular tachycardia, including atrial fibrillation and flutter, sinus and junctional tachycardia, AVRT, AVNRT, and atrial tachycardia. Keep those definitions in mind as we move on to our final video, in which we're going to put everything we learned together and get some more practice. Alright, see you in the last one.